Healthcare Consumer Access and Affordability meeting will be called to order. The agendas are distributed on the back of the room, and thank you for your attendance, and thank you to the committee. Before starting with our initial presenter, do any of the members have any specific items of business you'd like to review? Seeing none, we'll move ahead. If we could have Miss Amy Harris-Overby and Miss Ross Owen talking about population health programs and health strategies, come to the presentation table and introduce yourself. And thank you so much for coming and sharing your information with us. Thank you. Please identify yourself and feel free to dive in. And I assume that you're going to be doing about a 15-minute presentation and then be available for question and answer in a robust fashion.
Perfect.
Thank you.
Down there. The anticipation. Okay, there we go.
Good afternoon, Mr. Chair, members. For the record, my name is Ross Owen, Health Strategy Director with Hennepin County, and I'm joined by
Amy Harris-Overby, the Population Health Director at HCMC.
Thank you for the opportunity to join you this afternoon. We're here today to spend a few minutes talking about Hennepin Health, which is one of the ways that Hennepin County and Hennepin County Medical Center have tried over the last 5 or 6 years to innovate in the space of taking care of some of the most medically and socially complex public program enrollees living in Hennepin County. I'll spend a few minutes talking about the structure and makeup of Hennepin Health and the regulatory environment in which we operate, and my colleague Amy will talk a little bit about some of the design features that from a policy perspective have been important to us in this endeavor to deliver better care at lower cost. Hennepin Health is really a partnership between a number of different functions that Hennepin County and its subsidiary hospital and health system, Hennepin County Medical Center, operate. Hennepin County, as many of you are well aware, is a unit of local government that has a significant footprint in the healthcare delivery and financing space. Through Hennepin County Medical Center and its number of neighborhood primary care clinics serving a majority of patients on public programs around the metropolitan area. Also through the operation of North Point Health and Wellness Center, a community clinic and federally qualified health center in North Minneapolis, operated by Hennepin County. It's a variety of public health functions, including clinical services like health care for the homeless and a number of shelter sites, as well as a large outpatient mental health facility, and then rounded out and supported by its Human Services Department, which either directly delivers or finances many of the human services and social services that these same safety net healthcare recipients take advantage of. And so when we look at the strength of all of these pieces together, the goals of Hennepin Health since its inception as a demonstration project authorized in statute back in 2010 have really been to try to combine these components together, to align the financial incentives and behaviors of all of these system components to both address medical and social needs to deliver better care. In this partnership is really enabled by that leftmost bubble on our chart labeled Hennepin Health, which represents Hennepin County's licensed health insurance or health maintenance organization arm. And Hennepin County has operated its own health plan, formerly known as Metropolitan Health Plan, since the early 1980s. And under its goals of accountable care and integrated financing, Hennepin County was able to leverage the position as one of the Medicaid managed care options in Hennepin County to directly enroll patients or enrollees or members in the model and to receive that upfront total cost of care or capitation payment as other Medicaid managed care organizations do. And so the ways in which individuals become eligible for public programs and the ways in which they select or are defaulted into a health plan are no different for Hennepin Health than they are for any of the other medical assistance and Minnesota Care managed care offerings in the state. However, our goal is that the experience of care and the delivery system model that awaits those members on the other side of that enrollment is very different from what's been made possible under the traditional fee-for-service reimbursement models in healthcare. What we're able to do within this unique linkage or partnership between these different Hennepin County affiliated entities is to provide care that's limited to a defined network of clinics, meaning we encourage individuals who enroll in this insurance product to establish care with one of the clinics that's operated by a county entity. And we feel that's important in part because all of those settings of care, including Hennepin County Medical Center, are linked by the same instance of an electronic health record, meaning that we can coordinate care and communicate with each other in real time and share electronic information within that system to provide seamless, integrated, and coordinated care for those members. We also have been able, because of our common relationship to Hennepin County as a unit of local government, enter into a risk-sharing funding model, which allows us to really, for the first time, have all of these different players in the system that have historically acted very separately or oftentimes in opposition to one another to really be working under the same global budget to provide that set of Medicaid services and to, if we are financially successful, share in those financial rewards and to reinvest those dollars directly into the very systems that allow us to achieve those savings. We also, as I'll talk about in a moment, are talking about a Medicaid or medical assistance population that is very impacted by social complexity and social needs that are often the primary drivers of their expensive healthcare utilization. And so by bringing those broader functions of the county human services into our clinical delivery settings and thinking about those social realities of the lives of our members outside of the walls of the hospital and clinic, we have a better chance of impacting those healthcare outcomes, of doing preventive care and taking care of folks in a lower cost, higher quality setting than our acute care systems in which the safety net population often land. The primary population that has been served by this Hennepin Health model that I just described have been those whose Medicaid eligibility came about as a result of the Affordable Care Act's Medicaid expansion. So beginning back in 2011, as you're all aware, Minnesota opted to expand medical assistance coverage to a population of adults without dependents who at that time could make no more than 75% of the federal poverty level. And it is really this unique subset of the safety net population that Hennepin County and Hennepin County Medical Center have chosen to build this model around because of really the clinical leaders' recognition of that interplay between social need and medical need, and a recognition that being accountable for, being at financial risk for a Medicaid benefit for this population was going to require a very different way of delivering care if we were going to contain costs in this group, and that we really needed to leverage the strengths of the broader system outside of medicine and outside of traditional health care if we were going to be successful at achieving those outcomes. And so this slide tells you a little bit about the profile of this population, which brings with it some pretty significant crossover into other sectors of public investment and spending that many of us in healthcare don't think about throughout any given day. You can see that this is a population of disproportionately young men of color who, by definition and by virtue of their Medicaid eligibility, can have no dependents, are non-elderly adults, and do not have a disability that's been recognized as a basis for their health insurance coverage. And they are disproportionately impacted by mental health and substance use disorders. And as a population across Hennepin County, by our best measures, we think around half of this population is unstably housed or homeless at any given time. And so you can imagine, given this mix of often overlapping issues affecting a disadvantaged group of our fellow citizens, that really a unique approach would be necessary if we're going to achieve a different outcome, short of just handing out insurance cards and expecting behavior that's different. And interestingly, because we are positioned as a unit of Hennepin County, we of course are part of a larger organization that does a lot of work in the public sphere outside of health and healthcare. And we've been able to combine some of the data systems that are available to us to get a broader picture of how these individuals may be touching other systems as well. And when we look again at that Medicaid expansion population as a whole, going back to 2011 when that expansion happened, we see that that population makes up more than half of the county jail bookings in the Hennepin County Jail and makes up more than half of the emergency shelter stays that we see in our shelter system in the Minneapolis area. And so this is, while through the healthcare lens, a very small slice of the Medicaid population, through the lens of these other systems, in many cases, this is over half, a majority of the individuals that are seen.
Mr. Chair, I just have a quick question.
Senator Kiffmeyer.
Do you keep literacy statistics as well in regards to this population?
Mr. Owen, go ahead.
Mr. Chair, Senator Kiffmeyer, we do not routinely keep literacy statistics. The best proxy that we have comes from the information that is collected when individuals become eligible for public programs. We have information about education level, but not functional literacy across the board.
Thank you.
Thank you, Mr. Owen. Thank you, Senator Kiffmeyer. Please proceed. Actually, if you don't mind, actually, I think I'm just going to pop in with two quick questions. On your slide, the Hennepin Health HMO capitated program, and you had indicated that total cost of care, in a sense, then you function as an insurance company.
Mr. Chair, that is correct. We are licensed by the Minnesota Department of Health as an insurer, as a health maintenance organization that is operated by Hennepin County. So Hennepin County holds that license. We adhere to the same rules and regulations and requirements of all the other licensed HMOs in the state of Minnesota.
In Hennepin Health, how many insureds do you have?
Mr. Chair, we currently have an enrollment of around 30,000 individuals in the product, about 2/3 of which are this Medicaid expansion group that I'm talking about. The remaining 1/3 are mostly families and children on the Minnesota Care and prepaid medical assistance programs.
And I appreciate this information very much, Mr. Owen. Could you share with me approximately how much in that same capitated program Blue Cross, Health Partners, UCare, and Medica might have? Just roughly, you have 30,000, you said.
Sure. So that 30,000 is part of roughly 200,000 individuals across Hennepin County who are eligible for medical assistance in Minnesota Care. And you're correct in stating that Hennepin Health is one of 4 managed care offerings in that region.
Do you have numbers for any of the other providers in that regard?
Mr. Chair, I don't have them in front of me, but those are readily available. We can make sure that those get to committee staff.
And then it also indicated that you do participate in risk sharing. Has the risk sharing at times turned out to be an adverse situation for Hennepin County during certain years?
Mr. Chair, so you're correct. The risk sharing that I referred to in the slide is an agreement between that county-based insurer and its provider and human services partners that are also part of Hennepin County. And that's an agreement that we have entered into. And in every year of the program's history, there have been positive margins or savings or distribution available to go out to the partners. We haven't operated the health plan or the product within the health plan at a loss position in any of those years.
Thank you very much. Please proceed. Thank you.
And so this slide really just illustrates that basic hierarchy of need that's true for all individuals that many of us will remember from maybe a junior high civics or psychology class, and that we, of course, try to hold healthcare systems and insurers accountable for health outcomes, and that's very appropriate that we do that. And again, this slide attempts to really illustrate that if we're going to hold those health systems accountable, that we ought to and they ought to recognize that in order to get to a place where we can manage to the optimal care for some of the common chronic physical conditions that drive medical costs, in many cases, in order to do that, we have to address those basic needs, that we're not in a position to influence health outcomes until we've dealt with somebody's source of stable income or food on the table or meaningful employment or a place to sleep that night. And we think that by partnering with these different components of the system, we again are in a much better position to weave those needs together and to leverage the strengths of those other systems alongside what we do in our hospitals and clinics.
Mr. Owen, I think Senator Kiffmeyer has a question.
Yeah, another one back on your slide and where the risk sharing model. So it says Divine Provider Network with shared electronic health record. How do you, so you share that electronic health record with all of these entities? How do you do that in regards to some of the HIPAA requirements or patient consent or so on and so forth? What is the basis for that sharing?
Thank you, Senator Kiffmeyer. Mr. Owen.
Mr. Chair, Senator Kiffmeyer, all of the entities that are listed on that slide are linked to that same record, as you said. Hennepin County Medical Center holds a contract with, in this case, Epic is the electronic medical record vendor that we use. Those various county departments then have subcontracts with Hennepin County Medical Center to also use that same instance of Epic. And those agreements contain similar contract terms around all of the HIPAA regulations around data sharing and the necessary disclosure and consent forms that are required of all healthcare providers, that when individuals present for care, they either sign or opt in and opt out of those data sharing. And so in essence, that use of the electronic health record in our Hennepin County system is no different from the use of a single record across the Health Partners and Park Nicollet system or across the Fairview system.
Okay, thank you. Just one quick follow-up. You said you encourage people to choose HCMC, HMO. So out of that 200,000 total population, out of that total, 30,000 chose, roughly, we're just using big numbers here, chose to use your Hennepin Health as an HMO.
Mr. Chair, Senator Kiffmeyer, I believe if I understand the question that's partially true. I want to reiterate that the 30,000 or so individuals that have chosen Hennepin Health as their insurance are bound to that defined network of clinics, which includes a number of other notable additions to that county group, but that is the nature of our defined network product. However, Hennepin County Medical Center, North Point, those other clinics also take care of a number of patients who have other kinds of insurance that is reimbursed under separate contracts. And so an individual can make a choice of their insurer, and within the benefits available under that insurer, make a choice of provider. So there's a couple of different axes of choice at play here.
Thank you for that clarification.
Thank you, Senator Kiffmeyer. Thank you, Mr. Owen.
And so, Mr. Chair, with that, I'd like to hand it over to my colleague, Amy, who will talk through, again, some of the policy components that we wanted to highlight for the committee that have been useful for us in this work.
So as Ross described, this model started in a demonstration status, so in 2012, which enabled us to get started in serving that vulnerable adult population like Ross described. And we operated in that space for a few years, and we had about 10,000 members at that time. And then switched out of that structure and then moved through the competitive bidding process and took on families and children as well. So there was a shift for us in 2016. And so our population grew and then grew again now to be over 30,000, about 30,000 members. Most recently in May, picked up some additional members when there was some changes in the market. So now to date, we have both that adult without dependent population like Ross described, but we also serve families and children as well in the model. So when we reflect on the model and what has sort of made it a success, we sort of drew out these things that we wanted to draw your attention to, and some of them Ross has already described, but one of the things from a care delivery standpoint is it sounds kind of basic, but in order to know what type of interventions you should do or who you should reach out to, you actually need to know who the people are that need your help. And so at a most basic level, because Hennepin Health is an enrollment model, so it operates under this managed care frame, we know which individuals are in fact connected to us as a system and as an ACO partnership. And so that concept of enrollment actually is very helpful on the care delivery side, because then we know who it is that needs our care and services because they have that connection through Hennepin Health. The other thing that we think about has been really helpful for us is some flexibility for us to be able to use dollars in a different way. So yes, we administer the standard Medicaid benefit set, but we also have the ability to target some of those dollars in different ways. So an example of that is that, for example, there's a team of individuals that work for the county in the Human Services Department, and we want to make them available to our Hennepin Health members to help navigate to social services. Like Ross described, in that most basic level of the pyramid, we're trying to meet some of those basic needs. So we are able to, in fact, use some of our Medicaid dollars in very small ways to pay for a service like that, which is not a traditional health plan service. But we think it's an important way for us to meet those basic needs of the members that we serve. Ross has described the defined clinic network pretty well. And from a care standpoint, the more care that folks get in sort of close proximity to us, the easier it is for us to know that care is happening and be able to make those handoffs and connections. So the defined clinic network, from a care standpoint, is a helpful tool for helping us have better eyes on our populations that really do need help, making those connections. Another concept is the ability for us to take, when we've paid all of our bills at the end of the year and there's some dollars left over, we have the ability to reinvest some of those dollars into unique programs or ideas that we think can help further our ability to impact the population and deliver better outcomes. And so by having that local control and that ability to reinvest some of those savings, we've been able to test some interesting ideas, which we do every year, through what we call the reinvestment fund, to be able to solicit ideas from our frontline caregivers and others, sort of in the name of how could we better serve the needs of this population, and let's try something, and let's use a few dollars to really test that idea. And so that's been an important part for us of what has made Hennepin Health a success. We also have a lot of care model interventions that are aimed at those social needs, not just at the clinical complexity of the population, but those social needs. So we have invested and have teams embedded in our primary care clinics that have community health workers as part of the team. And their skill set is really being able to understand and navigate people and address some of those social needs that our individuals have. And that's a way for us to first meet those social needs, to then allow us to engage in care delivery to address some of the clinical needs as well. And I would say the last attribute is this collaborative governance concept. And so what I mean by that is that, so the partners that Ross described on that first slide, we all have an equal seat at the table. So the North Point has a seat, and HCMC has a seat, and the health plan has a seat. And we collectively make decisions in a very collaborative fashion, transparent fashion, about how we should operate as a collaborative. And so I think, to me, when I reflect on it, to me that's one of the things that makes it unique for us, is that we have this equal seat at the table. You want to talk about this?
Sure. And so the last point that we wanted to raise is just again to reestablish the context of this work happening within a unit of local government, in a county that not only offers some additional opportunities to intervene given the breadth of roles and of programs that are offered by the county, but also allow us to understand the intersection between these different sectors of public spending. And so we think that the longer term opportunity for models like this involve understanding the way that investments we make in the health sector impact outcomes in sectors like child protection and foster care, like corrections and like housing and vice versa. And we're really eager and gratified by opportunities to begin thinking about those funding streams more holistically, and to think not only about those impacts between sectors of public and private investment, but also really thinking about how to do the right kind of preventive work up front, which maybe doesn't fit within the typical time horizon of an insurance product that needs to perform year on year financially and achieve healthcare cost savings, but through more the lens of a public health or community or population health approach, which recognizes and makes possible investments in upstream work that will pay dividends down the line and ultimately make our healthcare system more efficient and better equipped to do what it does best. And with that, we are happy to stand for your questions.
Thank you both very much. I appreciate it. Questions from the committee. Senator Friends.
Thank you very much, Mr. Chair, and thank you, Mr. Owen, Ms. Harris-Overby. I had a question that's on the minds of those of us that represent rural Minnesota. You've talked about words like proximity, handoffs, connectivity, and eyes on the patient. Mm-hmm. How do these savings and benefits apply, in your opinion, to a rural setting? Hennepin County, of course, being the greatest concentration of population, and some of us representing areas that are a good deal more, less concentrated.
I guess I would offer that some of those basic components of collaboration and visibility, I don't think those are just distinctly metro characteristics. We have maybe a critical mass here in our population, but I think it's some of those hallmarks of success that we described. I don't think that they are necessarily metro concepts. Back in the day, I worked in a facility in Rice County, and so I think that I can look at sort of the coordination that happened there, or the ability for coordination in that space, and yes, you've got some miles between things, but I think the basic components of individuals having a seat at the table with some shared governance and aligned incentives and the ability to make those connections, I don't think of those things necessarily as being metro concepts.
Mr. Chair, Senator, if I may, I would encourage members of the committee to draw on some of the other folks on the agenda today who can speak much more directly to issues of rural health. One point that I would add to Amy's comments are that some of the areas where we see really common approaches being brought to bear on this work between both urban and rural regions is around just workforce issues and shortages of certain kinds of providers. And often we find it ironic that the same kinds of provider shortages in areas like psychiatry and addiction medicine are just as prevalent in concentrated urban areas. And so strategies like telemedicine and consultation models where we're using those specialists not only to see patients but also to educate and equip primary care providers to better deal with those conditions, where we in urban areas have actually learned from our colleagues in rural environments how to do that and how to stretch those resources more broadly. So I think there are some commonalities as well.
Thank you, sir. Thank you, ma'am. Senator Kiffmeyer.
Unless somebody else.
Senator French, did you have a follow-up? No. Senator Kiffmeyer.
Thank you very much. A question I have for you is in regards to where it talks about flexibility and spending Medicaid dollars. How do you get flexibility? I kind of see the theme running through here, care model interventions, social needs, collaborative governance, but it all kind of seems to be rooted in this flexibility. Could you just tell us more how you get that flexibility? Because Medicaid is usually quite strict.
Mr. Chair, Senator Kiffmeyer, the flexibility is largely the result of that managed care function that we operate. So the ability for Minnesota to offer its medical assistance programs through managed care is rooted in a federal waiver with the Center for Medicaid and Medicare Services in Washington. And part of that waiver allows health plans to essentially buy above the core benefit set of Medicaid. And so in the same way that health plans are able to offer things like fitness gym memberships to their members, a Medicaid plan can also choose to purchase or reimburse for activities or services that are not required by law or regulation. And under that authority, we can do things that a provider system that has to bill for things directly to a provider isn't often able to do. And so it's that flexibility afforded to us as an insurer that allows that to happen.
And Mr. Chair, was that a specific waiver for you in Hennepin County, or was that a general waiver for the state for anybody to function on this basis?
Mr. Owen.
Mr. Chair, Senator Kiffmeyer, that ability existed before Hennepin Health, and no additional federal authorities were granted for the operation of this program.
Thank you.
Thank you, Senator Kiffmeyer. Other questions? Thank you both for presenting. I have a few questions. I just want to summarize. So the expansion in 2011 brought in approximately 200,000 people on public programs. Is that correct? Is that what you had said earlier? Or is that just simply the 200,000 that's in this capitated program?
Mr. Chair, that 200,000 number was the number of individuals roughly who are currently in public programs in Hennepin County in this Medicaid and Minnesota care population.
And 30,000 of those are taken care of through Hennepin Health.
Mr. Chair, that's correct.
And Hennepin it's the largest safety net hospital in the state, isn't it?
Mr. Chair, yes, that's true.
Okay. And approximately what type of per member per month payment do you receive in terms of those 30,000 persons?
Mr. Chair, the per member per month payments are based on a risk adjustment formula, and so that amount will vary to each individual based on their level of severity or health care need. And so those can range anywhere from less than $100 per member per month up to many $1,000s per member per month. And those, of course, average out in different ways depending on the risk mix of the population.
Thank you. And we've legislated on integrated health partnerships, and of course that's a part of the ACO program. Is there anything that you think we could do a better job of in terms of crafting the rules and regulations for integrated health partnerships? You've obviously used a lot of those components in terms of your care coordination and your whole cycle of care that would allow us to more universally put this into place in greater Minnesota as well, getting back to Senator Francis' questions, are there things that you would specifically say, if I were king for a day or a queen for a day, this is what I could do, or this is what I would do to make this kind of approach more available? Because you're very successful in many ways, and I congratulate you on that. But one of our roles is, can we expand that success? Thank you.
Mr. Chair, I think I'd just clarify that Hennepin Health is a partnership that we operate under a managed care umbrella. So as a health system provider system, some of our patients have Hennepin Health insurance, some have Blue Cross, some have health partners. We as a provider system also participate in the Integrated Health Partnership. So it's sort of two different mechanisms that exist in the state where you can have different kinds of incentives to deliver different value. So for us, we've sort of layered these together at HCMC. We participate in both of them. And I would just say that they both have sort of strengths and weaknesses as models to drive innovation. I would say that the distinction I would make is this, that I think the nature of Hennepin Health for us is that we have a equal seat at the table with a sort of singular health plan partner. And so for us, that has created sort of greater leverage and greater change in our organization. But I would say the Integrated Health Partnership is also a strong model that can, in fact, create change. We just have the distinction of being in Hennepin Health earlier than IHPs existed. So for us, they both are a mechanism that I think are important.
Thank you, please.
Mr. Chair, I would add to Amy's comments a couple of things. One is that under both models, one of the features that we have found most useful is that transparency and availability of data, data which are often not available to a healthcare provider, but oftentimes are available either to state agencies or to healthcare payers or insurers. And so through different mechanisms, but under similar intention, both models really combine data from multiple sources and better equip healthcare delivery systems and providers to understand their population's needs and target interventions where they can have the greatest effect. So we would encourage continued pushing of data transparency and flows of data to provider systems that are interested in taking risk. And a second thing that we would really like to see continue to develop are approaches that recognize this social complexity that we're talking about in payment mechanisms for healthcare. And so I mentioned in response to your question, Mr. Chair, that the way that we get paid as an insurer is based on the medical risk of the patient population and does nothing to distinguish two patients with the exact same condition, one of whom is stably housed with a great family network and one of whom is sleeping outdoors in a homeless camp. And our experience has been that caring for that second type of patient requires a lot more resource, and that second type of patient is actually a much higher cost profile patient for the taxpayers. And if there are mechanisms either in setting capitation rates or in rewarding provider performance that marry that medical and social complexity, then we think that would be a more just way to distribute healthcare resources across systems.
Thank you. Other questions? Senator Pratt.
Thank you, Mr. Chair. I'm just trying to think through this a little bit. So is it this integrative system? Let me ask you're heavily reliant on public assistance reimbursement from public assistance programs. And we know that public assistance programs reimburse at a significantly lower rate than private pay. I sit on the board of St. Gertrude's Long-Term Care and Rehabilitation Center. So there's two ways to do it. One, you have to recover that cost that's not being reimbursed, or you have to drive down your cost so that it's closer to what you're being paid for. How have you been able to do that cost containment or revenue recapture to keep the system whole? Or, well, let me just start with that.
Thank you. Please proceed.
Mr. Chair, Senator Pratt, I would just say at HCMC, we have a similar challenge to what you just described. So our reimbursable payments, just the transactional payments from Medicaid, do not meet they don't match the cost for us to deliver that care. So from a direct provider standpoint, we have the challenge that you just described, and we are heavily government payer program funded as an institution, as a safety net institution. So the profitability or the success we're describing today is actually at the population level for the health plan. So there's the distinction of performance at the health plan versus the provider side. Do you want to add to that, Ross?
Mr. Chair, Senator, I would only add that, again, the ability to influence costs in this population is in some part a necessity for us because of the majority of our patients being public program. We don't have the same commercial or Medicare volume to sort of distribute those costs across. And we are also existing in a system in which Hennepin County and its property tax base is financially supporting the mission of its clinics and hospital. And so it's really a matter of how we become accountable and more efficient with those dollars rather than if we participate in Medicaid or not, given the mission and the payer mix that we have today.
Thank you. Senator Pratt.
Thank you. So when you so if you make that distinction between the HMO insurance portion and the provider portion, are you is Hennepin Health reimbursing at the public rate, or are they reimbursing closer to the private rate? And recognizing that then, as you described it, the provider piece of Hennepin County Medical Center is then probably having to collect or for lack of a better term, eat the loss on the other side. So how are you reimbursing?
Please proceed.
Mr. Chairman, Senator Pratt. So our payment at HCMC for the care we deliver to Hennepin Health members is paid comparable to the way we're paid by other Medicaid health plans. So it isn't at a greater rate. It's in the range of how we're paid for Medicaid. I think the way we look at it is we get paid for the care we deliver to individuals, but we also have, by sitting and participating in the Hennepin Health model, there's also the ability at the end of the year when there's dollars left over in the health plan structure. Those are dollars that come into us not just for the individuals that get care at HCMC, but it's at that population at the plan level. So there's a balance there for us in terms of there's the transactional revenue, and then there's the revenue that comes to us as being a partner through the health plan lens for a larger population, some of which get care at HCMC and some that don't.
To clarify, Ms. Harris Overby, when you say transactional, are you sort of referencing fee-for-service?
Yes.
Okay, so you're looking at it as a fee-for-service chunk of money for those services provided, sinus infection, sore throat, whatever. Mm-hmm. And then there's another pool of dollars that come through the, if you will, the relationship and agreement that's more on a total cost of care per member per month, capitation program, whatever you have it. Is that correct?
Yes, Mr. Chairman.
Thank you. Please proceed, sir.
Mr. Chair, Senator, the only thing I would add to the question of sort of cost or price in relation to the rest of the market is just a reminder that on the managed care side of things, respective of our downstream contracts or agreements, we do participate in the same competitive bidding process that the other health plans serving the public program population do. And so that input, that revenue that comes in per member per month for the capitation is within that same range of bids accepted by the state. And so from that standpoint, there's comparability as well.
Thank you. Senator Pratt.
Thank you. So one of the things we've heard about is the two issues. One, around fraud, waste, and abuse. That is putting about 30% of the, is eating up about 30% of our healthcare dollar. And the other piece is around low-value services. As an HMO, you have, I presume, the ability to manage some of that. How have you managed that to help keep your costs down?
Mr. Chair, Senator, I would say that in this model, issues of fraud, waste, and abuse have not been a primary area of focus. What I will say to your point on incentive is that certainly as a payer responsible for total cost, we are interested in addressing those issues and have processes in place to identify fraud, waste, and abuse and address it. However, what's different is that we now have that same incentive shared with our provider partners. Not to suggest that they are engaging in fraud, waste, or abuse, but what we do have are tools and rooms full of people looking at total costs and looking at what's driving costs and looking at where there's waste in the system in ways that they wouldn't have been incented to do before this model were in place.
Senator Pratt. Take a break.
thinking.
A couple of quick questions. In terms of the Medicaid expansion in 2011, you gave us a profile, and certainly you mentioned the complexities of the non-medical nature of so many of the folks you serve, and thank you for stepping up and taking such a large responsibility. But could you review for me one more time in terms of their eligibility, in terms of income level at the time of 2011?
Mr. Chair, at the time of 2011, with the early expansion, the income threshold was 75% of the federal poverty level, which tracked to the prior general assistance medical care program funded with state dollars. And then on January 1st of 2014, along with the rest of the country in the states that chose to expand Medicaid, that income threshold rose to 133% of federal poverty. So our population increased proportionally as that income level increased.
Thank you very much. Other questions? Senator Kiffmeyer.
Thank you very much, Mr. Chairman. So one of the things is was trying to figure out how you were different and how you're the same. And what I see a lot more is that, like United Health Group or some of these other ones, you're very much the same. And one of the questions that I had that seemed to be part of this whole process was the waiver, but also the fact that you use transparency and risk sharing as a real fundamental part of whether it was fraud, waste, and abuse, or efficiencies, or some of these things, that you use transparency and risk sharing. I just wanted to check and be sure that, you know, you're like a United Health Group, and then you use transparency and risk sharing to help navigate some of that efficiency, cost savings, and so on. Is that correct?
Please proceed.
Mr. Chair, Senator Kiffmeyer, I think in response, the ways that we are like other insurers have a lot to do with really the required core functions of a health insurer that we carry out. We ensure members are enrolled. We provide customer service functions for them. We ensure coverage of benefits. We process claims that come in and reimburse providers for those services. I think these trends, some of which we've talked about today, of using data differently and having unique partnerships between health insurers and providers are certainly not unique to this model and are happening in all kinds of other ways across different sectors of the market as well. I think some of the key differences that we would try to highlight in this conversation are that we are a health plan that's operated by a public entity, and that we are focused really quite narrowly on one geographic region, in our case the urban region of Hennepin County, and that our primary relationships and the environment in which we do this work is within really this system of, you know, one set of clinics and hospitals under one organizational umbrella. A larger health insurer with a regional or national footprint has hundreds and thousands of similar relationships that it needs to maintain. And so there are certainly trade-offs around the sort of ability and bandwidth to partner this deeply and broadly for a large population versus a small one, and there are economies of scale that come into play as well. So it's a complex answer to a complex question. I would say there are key similarities and differences.
Okay, very helpful.
Thank you, Senator Kiffmeyer. I want to thank you again. Hennepin County Medical Center comes up in so many of our conversations in the Capitol, and it's very helpful for us to understand that what you do and how you do it and what mechanisms you do it. So thank you again for presenting and taking your time with us. It's been very helpful. Thank you.
Thank you.
Thank you.
At this point in time, I would ask Mr. Jim Pryzbilla, the CEO of PrimeWest, to come and provide us information regarding health savings accounts. And thank you, Mr. Pryzbilla, for presenting. And please come to the presenting table if you would and introduce yourselves, and feel free to begin. Thank you.
Mr. Chair, Senators, good afternoon. My name is Jim Pryzbilla. I'm the Chief Executive Officer of PrimeWest Health, and I'll let the rest of my team introduce themselves as well at this time.
Mr. Chair, Senators, my name is Matt Magnuson. I'm the Director of Membership and Program Development for PrimeWest Health.
Mr. Chair, I am Jared Porter. I am a consultant from Certain Health Systems consulting on behalf of PrimeWest Health.
Thank you.
And I don't know how deep you want to go about PrimeWest itself, since you're interested in something that's kind of on our schizophrenic side as we work with PrimeWest itself was set up to serve very much what you just heard from Hennepin Health. We're owned, instead of by one county, we're actually owned by 13 rural counties under Minnesota's Joint Powers Law for the purposes of doing Minnesota healthcare programs under the managed care law in Minnesota. So we do many of the things, structured many of the ways Hennepin Health is, and indeed I would agree and mirror many of the things they're doing. And perhaps it goes to what Senator France was mentioning for rural, because some of the things that we do. Our total population in Minnesota healthcare programs is 42,500, and approximately 45% of those came with the expansion population and the expanded Medicaid, kind of moving toward a question you had earlier. So that's one part of what PrimeWest was. PrimeWest, as being owned by 13 counties, the counties face the struggles that many employers do. They're faced with rising insurance premiums for their employees. And over the years, PrimeWest began in 2001. Over the years, they saw their premiums provide health insurance coverage for their employees continue to increase on a yearly basis, 25% one year, 17% the next year, perhaps 25% again, always in a very steep trend upward. Somewhere around 2005, 2006, they started looking at PrimeWest saying, well, wait a minute, you perform all the functions of, we own an organization that basically performs the health insurance. Can we be part of our own solution? Now, that sounds easy, and you think it would turn the key that let's do it. But what we needed to do is get everybody in agreement that that's what they want to do across 13 counties, 40 different bargaining units within the unions within the counties, 28 different plan designs across 13 counties, and everybody at the same time feeling the ouch factor of their upcoming premium rate increases. Like I said, some years they're high, some years not so high. It was a matter of timing when the counties pretty much came together, I would say about 3 years ago, and said, it's no longer tolerable. And many commissioners, county commissioners at that time were saying, we no longer can look at this as an annual financial issue. We have to start looking at the long-term economic effects, because the wall of where we have the ability to levy or the pressure we can place on county taxpayers, we're hitting that wall. And more of our dollar is going for the benefits for our county employees rather than to salaries or to support the programs, many of which they share in the cost with the state or federal government. So they put us to task. The counties anteed up money to help develop that. PrimeWest itself as an organization, as a small employer, relatively, we have 135 employees, we were seeing our increases going as well. And of course, since we're pretty much 100% funded through the public programs, we thought it was in the best interest that we try to control our internal costs as well. So we also threw our lives in. Now, if you look at this, up to this point, all the counties were basically individually rated. And you'd have employees, a number of employees could range from right around 100, maybe up to a couple of hundred. And so they were very vulnerable to catastrophic illness within their employee base, driving their premium up for the upcoming years or the successive years. The strategy behind ours is pretty basic. Law of large numbers. The more people, the more premiums, a large pool. So instead of going the route of using PrimeWest, which unlike Hennepin Health, which is organized under the HMO law, PrimeWest is organized under the county-based purchasing law. Many of the same checklists of regulations and laws that we have to follow. We're just not a authorized HMO. So we would have had to set up an HMO to do that function because we're authorized under the PMAP law. We may bring this to your attention sometimes in the legislative session coming up. But, so we took a different route. How can we pool the lives with existing things in statute? And we came across the political subdivision joint insurance pool. And what it required was the 13 counties basically to pool their lives together as in one purchasing group and pool, and then following those statutes. And in that scenario, PrimeWest becomes the administrator, so we're basically leasing some of our functions to an independent group. And that group, by the way, and this is going to confuse it more, we're PrimeWest Health. That group is called Prime Health, and I'll try to even keep those straight in my mind as I present today, and Matt and Jared will as well. And then that is the one first step. This is very basic, get more lives into the pool. And then what can we do that's been shown to demonstrate increased engagement and responsibility on the consumer in terms of their healthcare decision-making and their health behaviors? Of course, one of the tools that we know is common is the HSA. And so that plays a big role in that. And we're not doing, when we designed the program, we didn't do with anything with kind of wild actuarial assumptions that we can move mountains with our care management model or different programs designed to help people with chronic illness or sickness or engage in healthy behaviors. We're going in with the basic numbers. Here's how many people currently will have enrolled. Here are the basics of doing it. And if we find once we're in the game, there needs to be things brought, programs develop at that time. If you're familiar with Bill Walsh and his approach to coaching the San Francisco 49ers during their glory years, they script out the first 15, 20 plays. Then you see what the response is in the environment. So we're not going in with a lot of bells and whistles. We know the numbers seem to work. The tools that we're using and the concepts behind it are well-founded and well demonstrated throughout the health insurance industry. And we're simply applying that in a rural setting and leveraging our private-public partnerships that we have in rural areas and exercising a lot of self-determination and grassroots stuff to get there. That's all I'm going to say on it because I actually stepped out of the development of the product because I did not want to be so close that I could not make a very good decision on behalf of PrimeWest of whether or not PrimeWest wanted to enroll in the Prime Health product. So this is how bizarre it gets. So I'm going to turn it over to Matt Magnuson and Jared Porter at this point to give you the more details of the HSA component of this.
Mr. Chair, Senators, as Jim talked about, the Prime Health program was designed for these 13 owner counties, and what they were really looking to do was just control the rising cost of premium that they had. And so what we did, Jared and I, is we really gathered as much data as we could from all of them, and we got 3 and 4 years of all of their claims and utilization data to look and see, could we have done anything different? And one of the big things that came up was this idea that they were so vulnerable to just 1 and 2 big claims as any one group. Even 300 employees, a group of 300 employees, $1 million claim or a couple $500,000 claims was causing that group to get a 20 or 30% increase in the next year. And when that happened, it was starting to cause some of their families to double think whether it was cheaper to buy coverage through their county or to leave and go to the open market or go somewhere else. And so these groups were actually getting smaller over time as their rates were increasing, which was causing rates to go up at an even faster pace. So when we sat down to do this, kind of the first thing we came up to as the key for this was this idea of a new pool. And in order to create this political subdivision self-insurance pool, what we had to do was really create this kind of feeling that it was all for one for all once you were in the pool. You couldn't look anymore at your individual group because in any one year there's going to be a group that's going to be better than the overall pool trend, and there's going to be a group that's a lot worse than the overall pool trend. And we really had to get counties to understand that commitment that they were making to this is that you might be better than the overall pool for 2 or 3 years in a row, but you don't know when that next $1 million claim was going to come that was going to cause this next spike and increase in their rates. And so the feeling here was that the counties actually are joining this new pool now, and it's kind of a 5-year commitment for them to get in. We actually had set up as a group, these counties agreed to, let's charge a penalty if somebody leaves the pool early because they're actually hurting everyone else in the pool if they left. And so we did some of those things so that we could keep this pool together long term. And the idea behind this was we had 45 bargaining units and 28 unique plan designs. And when we went through the actuarial model of this, if these groups had just come together over the last 4 years and decided just to even share risk, we're not going to change plans, we're not going to change anything else. If we were just going to share our risk equally like we are in this new pool, the rate of increase would have been about 6% per year, which some groups had been doing better than that, but there were a lot of groups that were doing a lot worse than that. And so the idea here was we knew we were kind of onto something. It was about not saving money for 2018 or 2019, but if we can look out to the future and look at what does it look like in 5 years if we don't try to do something different. And that's really what we wanted to focus on here, was long-term rate stabilization. So once we had kind of the counties and the commissioners, understanding this idea of what this pool needed to look like, now we had to spend a lot of time working with these employees and bargaining units and really spending time with them. And what we did is we created regional task force meetings where we went out and set up groups where we actually met with the union representatives from all of the unions within the counties, the employees, the HR staff, and we talked about benefit designs because we had to now create a pool where we're going to share risk equally. We couldn't have 28 individual benefits. So we had to come up with some standard set, and I believe you got a handout earlier that has some of those towers on there. And what came out of that group was the understanding from employees was the idea of, what's the best use of your premium dollar? And so we really put it in terms of that you have to buy insurance for those $10,000, $20,000, $50,000 claims. But if you look at one of the handout that has the 4 towers on it, when we gathered the data, there's a little bubble or a teardrop kind of off to the side of that emerald tower, and it's probably small on yours, but what it says is what we found in the data over those 4 years was that 47% of all of the people in this pool were spending less than $1,000 a year on health care. And so when we started to look at that, and we talked to those employees, and the half of the employees that were in these traditional plans, they were our best utilizers. They're the people that are helping us keep costs down because they're using healthcare wisely, they're going in, they're getting their prevention, and they're doing the things they need to do, and they're spending less than $1,000 a year. In the old traditional deductible plan where they had a $500 or $1,000 deductible, their reward was you started January back at zero, and you had to pay the first $500 or $1,000. And so as we walked through that with employees, they started to like the idea of, hey, if I have this premium dollar I've been spending, why can't we focus that coverage to where the majority of people are going to use it? And so that's what we did in building these plans, was we focused on building this HSA that was kind of fully funded through the premium. So when we built premiums to the counties, each one of the premiums included, if you look at this chart, there's $1,350 of HSA. So we built $112.50 into that premium to ensure that each employee was going to have a funded HSA. It wasn't going to be that choice anymore where they enroll in an HSA plan and they don't fund it. We wanted that money to be there for them to use as they went through this. And then as we kind of moved forward, we looked at kind of some other benefits, and we created these kind of next tiers. As you look, the difference between those plans is that $1,000, $2,000, $3,000 window there, and it's 100% plan covered dollars. And so again, we were trying to focus the insurance to where the majority of people were using it instead of the other way around. And we did that because if you look over, there's another little bubble or teardrop there, and the second one over says 67% of all the people were spending less than $2,500 in a year. And so we had these plans now where 2/3 of all of the people could choose a plan where they were no longer going to have copays, and they were no longer going to have any out-of-pocket, and they were going to kind of get the maximum benefit from the insurance that they'd been paying for. And as we started to work more and more with employees, they got excited about this concept and idea, and they started to talk to other people that had HSAs that were going, and people had real balances in there. And then the stories started coming up about how, members never realized how much a prescription cost until they moved to an HSA plan. And I'm sure you've all heard one of these stories before, but they've paid their $30 or $40 copay for a medication forever. And the first year they switched over to an HSA plan, they went to pick up their medication in January, and it was $450. And they were, whoa, we can't pay $450 for this medication. So they call their pharmacist or call their provider, and they end up finding one sometimes that was less than the original copay they were paying. They find find a medication that's $8. Well, they never even thought to ask the question when they were on that old copay plan. As soon as they moved to a high deductible health plan, it was the first time they kind of became engaged in that thing. They found another medication that could work for them that was less, and overall that saves the plan and pool money. And the idea behind this is where we really got employees to buy in was started to show them that we're one big pool. The money we collect is all of our money. You know, if we have to spend $1 million on this person over here, the rest of us are going to have to pay for that. So the better and smarter we can become as consumers, the better off we are, and we can keep that money within our pool long term. And so that's really kind of where this concept of this first dollar coverage in these HSA plans really came from. And we're hoping that it does start to turn that, to get these consumers more involved. We want people to start building balances in these accounts, as well as asking the questions about how am I spending my money? How am I spending my healthcare dollar? Because ultimately, in a pool like this, it's the consumers that are driving the cost more than anything. It's our utilization as consumers that are driving the cost. So. Jared, maybe anything to add to that?
Mr. Chair and Senators, I will add a couple other points that I think are important. When we're talking about the groups experiencing low rate increases and then high rate increases, a rubber band effect from year to year, that is really a function of the market driving a risk rating method. You know, risk rating, giving credit for low risk, and then immediately charging up the following year whenever there is a bad experience. Ultimately, what we committed to do is, over a time period, move all these groups to community-based rating. And that, as a structure, you know, as the pool within the region, they will all be paying the same rate. We added a little twist on that the community-based rate will be age-banded, so depending on the average age of a group. But we wanted them to understand that the consequences of the environment of risk rating causes, you know, a year where they may have a 0% increase followed up by a 35% increase. And so when you look at national trends and see national trends reporting a 6% increase, they're averaging, you know, all health plans. And we wanted them to say, if you want to achieve that type of predictability and reliability, you need to move to community-based rating. And that took some education, but they really bought into that and understand that, you know, this is a pool of all of them together, working together to, you know, not look at their financials in 1 year where they want to, you know, what they can best achieve with their premiums, but have a long-term view of, you know, responsible, stable rate increases from year to year. And so they bought into, you know, the community-based rating. And then, again, when we look at the plans that, again, these plans were essentially developed by doing these task force where we met one-on-one with all the members, the union leaders, to develop these plans and moving everybody to these HSA plans, these consumer-driven health plans, we believe empowers the individuals to kind of be the force for change in driving down healthcare costs and giving them the tools. And so that's where we truly believe if everybody becomes, you know, involved in their consumer decisions, that's where we're going to actually start, you know, allowing them to be the force for change that we want out of this pool.
Thank you. Any questions, Senator?
Thank you very much, Mr. Chair. I really appreciate hearing about this. I have actually written about this many years ago, because if you don't incentivize the consumer themselves and use information that helps them make their own transformation, making those kinds of choices, and that they get the gain in the end, instead of saving so somebody else. I mean, there is that general together kind of a thing, but as far as that approach, and it kind of takes the balance of consumer having that power and that choice, not always feeling like you're being dictated to, and an HSA is uniquely suited to that. But my question here is, though, results. And so I appreciate the average, you know, 6%. And so over the years, what has been your premiums and how has that, I like to see, I appreciate the snapshot of a 1 year, but I also appreciate having, how did it go? How's your trends going?
Mr. Chair, Senator Kiffmeyer, I hate to disappoint, but this is a brand new program. It's actually starting January 1 of 2018. So we have no experience to present to you.
Okay.
I should have presented that. I was remiss in not mentioning at the beginning. My apologies.
Mr. Chair, they've done so much work in laying this out. It's a compliment to you that it looked better. I think functionally, though, nationally, there are HSA statistics and stories. I'm sure that's one of the reasons why you took a look at this.
Oh, definitely. Again, innovation is sometimes taking the parts of different things and putting them together and repackaging. HSA has been around, the whole concept of the law of large numbers, joint pools, and things like that. The unique part of this is really getting people to buy into a long-term commitment, working with bargaining units, actually having the beneficiary involved in designing the benefit set themselves, right down to deciding what providers would be in the network. We hear good and bad of the narrow network. If they wanted to have a bigger network, they knew it was going to fall on their premium. They had to make that decision whether a Mayo Clinic or others would be included in the network as well, but they understood the cost involved in those decisions. So from the very beginning, the idea was to get a high degree of sensitivity on the purchaser's behalf, to understand here's what drives cost. And of course, the HSA is more about the behavior of the individual, but you can do things as a group and move in that. But we were saying at the beginning, it wouldn't be something that PrimeWest would go off in a secluded barn and come up with an idea, and here you go. It really had to be designed by those that would be the beneficiary of it, or the ones that are going to be paying a big share of that being the county taxpayer.
I want to commend you for that, all of the education and all of the conversations that you've had. That's really positive. You don't see that much. I mean, the other methodology is you do this, and you kind of are in this, something's happening out there, and I think that's very positive, and just want to commend you for engaging them, because you're exactly right, and that's what an HSA is fundamentally based upon, is a more educated consumer in order for it to work well. Thank you.
Thank you.
Thank you, Senator Kidmore. Thank you, presenters, and Senator French.
Thank you, Mr. Chair. Thank you very much, presenters. So good luck starting on January 1st. My question's for Mr. Pryzbilla. Talking about pre-funding HSAs, does that idea come from somewhere else? Have we seen that at work in other marketplaces, other plans? Just a case of first impression. Just curious, for the committee's sake, if you've seen that everywhere else, and if so, how did it work there?
Yeah, Mr. Chair, Senator Friend, it's not really, every group will pre-fund it different. Some are going to put the full $1,350 in January 1, one way of pre-funding. Some will put $112.50 in monthly. What we wanted to make sure was that at a minimum, every employee was going to get that full $1,350 put in there annually, so that they didn't, a lot of times what happened was you would have an HSA offering as a new plan option in an employer group, and people would select it because it had the lowest premium, but they would never take that premium savings they ultimately had coming from their old traditional plan to the HSA and put it into that HSA plan. And so what we wanted to do was really not leave them an option. They can do more, but at a minimum, they have to do this $1,350.
Thank you, Senator French. I have a question, mind whoever answers this. In constructing this originally, so it's a county-based program, and it's worked. And we still have individuals in the individual marketplace who would like to be able to also form a group. And legislation that we passed earlier this year allows greater opportunity for that to happen. Is there a downside? Is there something that you see where the legislature could go too far in allowing small groups to form? I mean, obviously, when you allow smaller groups to develop like this, you do shrink the individual marketplace. But beyond that, in the process of constructing, and you've done this since 2001, I think you said?
Yeah, we.
What would be the warnings that you would give us, and what would be the benefits if you tried to break?
In terms of counties wanting to do county-based purchasing, first of all, the realization, and this is going to be a managed care organization saying something about regulation. There are important regulations to have, and you have to cover the basics. You have to be able to prove your solvency and demonstrate that, and have the safeguards that ensure the solvency, especially when you're dealing with taxpayer dollars or anybody's dollars when it comes to a purchasing arrangement. You're entrusted. Second of all, you have responsibility for the quality of care, and there are regulations around those. Third, you want to make sure they have access to care where physical access is available with those standards. You have to meet those, and those regulations that Minnesota has created around those three areas are very important. And now the fourth and emerging pillar is those regulations around fraud, waste, and abuse, and have the ability to control, manage, prevent. Those are the things that I think are daunting because there are a lot of regulations. There's some probably extra regulations, then there's probably some overkill. But at the same time, that's the thing that would separate who are sincere about their conviction that the county is in a very good place to integrate public health, social services with local medical in public-private partnerships to better integrate and coordinate care. And that'll separate those who see this as a way of taking surplus or making surplus from a state program. You know, what we do as surplus is we basically treat it as seed corn. If we're saving money from some things we're doing, we take our surplus and reinvest it into those ideas that continue to reduce costs more and more, improve quality. So that's our approach. But that's something why, if you see our unique geography, we've had a lot of counties approach us, but look at this strange geography on that map. These are 13 counties that share that concept. So our community is not defined by geopolitical boundary. It's basically a shared value that we're in a pretty good position to do something. There are certain regulations that are hugely important. We need to oblige them, but we also take a look at, when you're engaging a county in a public programs, the county can't quit. They're quitting on their constituents. So when they take it on, you have to understand there are certain things that are important to protect on your constituents that are regulated under state and federal law. You have to make that commitment. And that's what separated a lot that have done county purchasing, and there's 25 counties statewide that do it, those versus those who have not. There are many more who want to do it. I think it's really them figuring out how to do it and then testing their own commitment. And then that can roll off to do things like, well, we developed the expertise. Can we do something with the county employees? You know, again, let me stress, it's never been the interest of county government to get into the private sector's business. And PrimeWest, one of their fundamental values is we step in when the private sector is unable or unwilling. I come from a very conservative area of the state of Minnesota, and even if they're liberal, the reality of the finances at the county level is you have to be conservative fiscally. You have to look at things. So that's the approach we've always taken. And in the case of why PrimeWest started up and why Prime Health there was an absence of something in the private sector to address an emerging and urgent need in these 13 counties.
Thank you. A couple follow-up questions in that regard. So I understand your model. You've got the Emerald, Ruby, Sapphire Diamond, and I understand the plan dollars go towards funding the first 1350 of the HSA, and then to cover the next interval chunk depending on choice made, and then you've got the members stepping up, and then you've got plan dollars covering above 6550. The plan dollars, I assume, come from the premiums that the employer county is paying on behalf of their employees, correct? What happens, do you insure with another insurance company for if you will, the high cost? Is that a secondary reinsurance?
Yeah, we'll have reinsurance at that point, yes.
Could you just comment on what you do there and where you go for
Go ahead.
services?
Sure.
Yep. Mr. Chair, for reinsurance, what we're looking at is we would purchase individual reinsurance. So it's not a stop-loss program. We believe the numbers are fine for the entire pool, and so we purchase individual reinsurance, and we select the deductibles for that. And so you're looking at, your cancers, your preemies, those would be covered under the reinsurance that we purchase on the open market, yes.
Thank you. Any other questions? Seeing none, thank you very much for sharing your information. HSAs obviously is a tool that can help people become better, more involved, engaged consumers, and as such could bend the cost curve down, and that's exactly why we appreciated your coming before us. Thank you.
Thank you very much for the opportunity.
Thank you. Thank you. At this time, I would like to call Mr. Chris Messerly to present on a medical malpractice discussion and help us understand how the cost curve of healthcare expenditures might be bent downwards if some form of a tort reform or consideration was to be undertaken. Thank you.
Thank you.
And welcome.
Mr. Chair.
Mr. Messerly has a couple of handouts.
Please, sir, go ahead and hand them out if you'd like. That'd be great. And introduce yourself and begin.
Thank you, sir. Mr. Chair and Senators, my name is Chris Messerly, and I live in Vadnais Heights. I work in Minneapolis, and for the last, I guess it's more than 30 years now, I've practiced in the area of medical malpractice. I'm with the Robbins Kaplan law firm. I've represented mostly plaintiffs, but I have had the occasion every year to represent physicians as well in defending them. So thank you for the invitation. I think the state of the medical malpractice law in Minnesota is very good. At least that's certainly true if you're a healthcare provider or in the medical malpractice insurance industry. There was a report that just came out last month, actually this month, October 2017, Medical Liability Monitor, which is an annual rate survey issue. It's put out by the medical malpractice insurance industry, and it lists Minnesota, which has been typical over the years, as having some of the very lowest rates in the nation for medical malpractice premiums. So it's a good place for healthcare providers to be. In fact, this same edition notes that overall, premiums for healthcare providers have been decreasing 1.1% after many years of no increases at all. I wish that was true for my auto and home insurance. I think there's a bunch of reasons that I will cite why the environment is so good for healthcare providers and the medical industry. One has to do with simply the screening of cases. Back in 1986, which happened to be the year I started practicing, the legislature here passed a law called the Expert Affidavit Law, for lack of a better term, 145.682. And what that did was set a number of requirements and raise the bar significantly to make certain that cases that were brought in Minnesota were very meritorious and would screen out the possibility of having any frivolous cases. It's a very high burden for patients to meet, and if they don't meet it, the court is under the obligation to dismiss the case with prejudice, which has led to screening of cases, which quite frankly keeps a lot of cases out of the system. I'll give you an example. There's probably about a dozen lawyers in Minnesota that do plaintiff's medical malpractice full-time. And for our firm, for example, the largest firm handling it, we take about 2% of the cases that come to us. And I think that has a lot to do with that law that was passed many years ago. And also, the GAO has stated more than once that Minnesota really should be the national model for how you manage medical malpractice litigation. And it's obviously worked given the statistics from the malpractice insurance industry. The U.S. Chamber of Commerce is also very helpful, I think, to look at what they've studied. They came out with a report last month that listed Minnesota number 4 as the best state to be in for a defendant. So anyone who's being sued, a healthcare provider or hospital, there's almost no place better to be in the United States than in Minnesota. It has a lot to do with the competence of our jurors. We have a bright jury pool that usually gets it right. And likewise, the Chamber of Commerce cited the competence of our judges. We have a great judiciary here. And they have an obligation and take it seriously of making sure that a frivolous case could never see the light of day. The primary insurer for malpractice in Minnesota is MMIC. It's a company I've worked with regularly for the last 30 years. They do a very good job at aggressively defending cases that they feel are not meritorious. And they also do a very good job of keeping premiums down, which I think is evident by the fact that we have the lowest premiums in the nation. There's another thing, that very, very few cases are filed in Minnesota every year, malpractice cases. If you look at the statistics that are put out by the Minnesota Supreme Court that are available, there's been a drop in malpractice filings from 2007 to 2016, less than 100 filed last year. So they've either stayed steady or declined according to our Supreme Court. So out of the nearly 400,000 civil cases that were filed, about 1,000 were medical malpractice cases. And then I think another good thing is that there's very little defensive medicine practiced here. I know that the GAO has kind of debunked this thing about defensive medicine, and I think most studies have, but we still hear about it. But I will tell you, in my 30 years, I don't think I've ever had a malpractice case because someone performed too many tests. And as MMIC has recognized in their publications online, it's usually because a healthcare provider fails to do a test. So thankfully, I don't think that's an issue here. So I think what's great about Minnesota and what makes me proud to be a lawyer and a citizen here is that Minnesota does a great job protecting everyone's constitutional rights to a jury trial, to let a jury decide fairness. And by the way, when juries do decide fairness in medical malpractice cases, doctors and healthcare providers come out on top about 85, 90% of the time. So I think the jury environment is good. Not so much if you're folks I represent patients, but it certainly is if it's a doctor or healthcare entity. And we do that despite the fact we have no caps of any kind. In fact, every state with caps has higher insurance premiums than we do. So for Wisconsin's one good example of that. It's interesting to note, and I almost forgot about this, but there were, in fact, caps on damages back in 1986. The legislature imposed a $400,000 cap on non-economic harm, pain, suffering, disfigurement, things like that. And it lasted only 4 years before our legislature and governor had, at least I think, the good sense to abolish it, because they learned, and there's a study published on this, that it did nothing to reduce costs. And I think most significantly, the caps, as any caps do, I think they hurt disproportionately women, minorities, and the poor, because if I represent a rich white banker who has a massive wage loss, they may get $1 million out of a case. A mother and homemaker who arguably has every bit of an important job, if not more important than the banker, because they don't earn an income, their case with the same injury may be worth only $150,000 or $400,000 if you had the cap back then. So I think what the legislature had seen was that we did make a mistake, and they fixed it, and things have worked wonderfully ever since. So I think the state of the law is good. I think if anything, I would encourage the legislature to look at things that do a better job preserving the rights of victims of malpractice. I mean, according to studies, more than 210,000 people die every year from preventable malpractice. That's 210,000 a year from preventable malpractice. And I think we could do things like changing the statute of limitations for patients to 6 years rather than 4, because the only exception in the law to negligence that limits the rights for Minnesotans, Minnesota families, is the fact that it's a limited statute of limitations only in medical cases. All other people are treated differently. So that's one thing to consider. And that's, Mr. Chair, really about all I had to say. I'd be happy to answer any questions you or anyone has.
Thank you very much, Mr. Messerly. I appreciate your coming and sharing that perspective. Questions from the committee? Senator Frentz.
Chair, and thank you very much, Mr. Messerly. Just a couple things, if you don't mind. You used the numbers 85 to 90%, and just for the committee's benefit, you mean of the cases that go to verdict?
Yes, sir. Yeah, Mr. Chair, Senator Frentz, exactly. Of those 100 cases that are filed, they don't all go to a jury or verdict. Some are dismissed and some are resolved. But of those that are tried, patients lose. Doctors and healthcare providers win about 85, 90%.
All right, thank you. And if I could follow up, Mr. Chair.
Please feel free, Senator Frentz.
Practice the same number of years as you have, Mr. Messerly. One of my observations is that doctors do a better and better and better and better job, which might explain the decrease to some extent in the number of filings that you see. The question the committee really wants to know, though, is we're trying to bend the cost curve down. And so having heard your testimony about the things you do like about Minnesota's medical malpractice law, I think our question is, are you suggesting things that can decrease costs for patients, whether it be through practice, anything like that? In other words, we're trying to save money for the system. Do you have any suggestions on that part of it?
Well,
Thank you, Senator Frentz. Please proceed. Thank you.
I'm sorry,
That's
Mr.
fine.
Chair. Senator Frentz, the juries kind of do that for us already. And the law that we have that this legislature set up in '86 to keep cases out of the system has I mean, clearly, the facts speak for themselves, has done a better job than probably anywhere in the country on keeping costs down. So from the standpoint of, I mean, I wish I had some better suggestions of what to do in the state, but from a medical liability standpoint, you know, I don't see much that can be done. I mean, putting caps on something clearly won't help. That's been proven by the facts. So I don't know if I'm answering your question properly, but it seems to me you don't fix something that's working well.
If I
Thank
could,
you. Please follow up, Senator
I'm sorry,
France.
Mr. Chair, but just one last question. You talked about the affidavit requirement and your feelings about it. Do you mind for the committee just saying a tiny bit more about what's involved in obtaining the affidavit in a typical case?
Thank you. Please proceed.
Yes, thank you, Mr. Chair. Senator Frentz. Yes, it's a very detailed statute. There is more than one affidavit. First of all, no lawyer can start a lawsuit unless that lawyer provides an affidavit, him or herself. And that lawyer's affidavit that would accompany the complaint that starts the lawsuit must say that the lawyer has consulted with a competent and qualified expert who has concluded, based on what the expert knows, there is merit to the case. But that's not the most significant one. 180 days after the lawsuit is started is when, well, I guess, the big affidavit, for lack of a better terms, is required. That is a very, very detailed affidavit, usually many, many pages long, signed by the lawyer and by the physician, in which it lists in great detail all of the facts that support the expert's opinion, every one of the expert's opinions, and the basis for each and every expert opinion, and it often includes medical literature published by the medical industry that supports that opinion. So they are very detailed, they are very long, and it really shows all the cards, so to speak, for any patient who's bringing a claim. And that's the affidavit that, if it is not sufficient, that statute commands that the court shall dismiss the case with prejudice, and that happens. That judges doing their job, as the Chamber of Commerce notes, gets rid of them and keeps them out of the system. That's probably why there's so few cases out there.
Thank you, Mr. Messerly. Thank you, Senator Frentz. Other questions? I have a question, sir. Thank you very much for presenting. Our objective in this committee is to brainstorm and explore as much as we can, bending that cost curve downwards. And there are many very positive things about the situation of medical malpractice in the state, and you've done a nice job of articulating them and demonstrating data to support your perspective as well. What we're concerned about is that insidious underlying inclination on the part of providers and hospitals and therapists to, oh, well, we better go ahead and do this one more test just to cover our backside.
Yes.
And I think that's the hard part. It's hard to measure. And you made some comment about it, and I wouldn't want to try to paraphrase exactly, but I thought you said something to the effect that you're not seeing a lot of lawsuits because people are doing too many tests. Rather, they might not do a test that might have uncovered a diagnosis earlier. Is that correct, sort of?
Right.
Okay. So I think that's where we're wondering how many low-value services are being ordered by physicians because a patient has an inclination. I could perhaps give you an example from yesterday afternoon. A fellow told me about his wife's frustration with his inclination to snore. And after a few moments of conversation, it was evident that what we were moving towards was a full assessment of the potential for obstructive sleep apnea, which would require a polysomnogram, which is basically your overnight sleep study. And basically 98% of those polysomnograms are generally followed by a CPAP machine trial of less than 30 days. And then usually the insurance company purchases the CPAP machine, which then within 3 to 6 months in 75% of situations is collecting dust in the closet. So if I sound skeptical there, it's because I'm skeptical there. But this is where this underlying expense comes into our healthcare, and it comes in every day. I had a malpractice suit against me once in 1990, and knock on wood, I'm glad I haven't had one since. But I know that it changed me. And every time I saw that kind of patient present, I was inclined to throw everything, including the kitchen sink at it, to make certain that I wouldn't be guilty of not ordering a test that might have uncovered something. And I think that's where we're at. And I regret that Senator Klein had to step out for a moment, because I'm going to guess that Senator Klein, in his work as a hospitalist at Hennepin County Medical Center, has seen the same thing. I know some centers in the state frequently will repeat tests because they don't have the same confidence level in the preceding test that was done as they do in their own facility. So the test will be repeated. And sometimes those tests are high-dollar tests.
Right.
And so to manage the cost of care is difficult. But I do think that physicians do practice at times from fear. That's really where we want to go. We're not interested necessarily in looking at the statute of limitations or saying that lawsuits are bad. We're just wondering, is there something we could do without disrupting what appears to be a pretty stable, solid situation? Is there something we could do to bend that cost curve down and reduce the number of low-value services that are being ordered? Do you have any thoughts on that, sir?
Yes, Mr. Chair. Well, for one, you could enforce the Medicare fraud rules, because if a physician performs a test that's not medically necessary, that is fraud. And that is why most physicians, I see in our experience, do not order unnecessary tests, because, quite frankly, it's illegal. Another reason, and there's many studies on this, and if you look at the GAO report from, I think it was 2003, they really debunked what most would call a myth of defensive medicine. Another primary reason, according to studies, that there are unnecessary tests is that, I'll give you an example, a clinic orders a brand new state-of-the-art MRI machine, and they have an inclination to order more tests to use that machine. And that's been shown as one of the drivers for why unnecessary tests are performed. So aside from stories about this being done, I think almost any study, and I could provide probably many studies to the committee, it really isn't an issue. It certainly isn't in Minnesota, because I think we have competent healthcare providers who are confident in their decision-making process and what's necessary for patients, and they're not out ordering unnecessary tests. I guess that's all I have to say, Mr. Chair.
Thank you. Appreciate it. Any other questions? Senator Kiffmeyer.
Well, thank you, Mr. Chair, but your direction, and the question was mine as well, and how we can determine between those. I think the challenge always is, after the test is done, then you know. But prior to the test being done, you don't, and that's kind of the whole point. Although I have seen sometimes on some like the CPAP situation, without doing the full study, you can try the cure, and if it works, you can go backwards and say, well, then that was probably your problem, because it's a symptomatic treatment versus a surgical kind of a thing. But so I think there are things that could be done in that kind of approach that I think would be helpful. But that was kind of my question for him as well.
Thank you, Senator Kiffmeyer. Other questions? Mr. Messerly, I certainly appreciate your willingness to come before us and share with us your perspective. It's helpful, and I think you understand the work we're trying to do, and thank you again for presenting.
Thank you, Mr. Chair.
Thank you. Yeah. At this point in time, I would like to announce that we originally had scheduled MMIC, malpractice insurance insurer, to present in sort of an opportunity to present both sides of that equation, but they were unable to present today and had to cancel. So at this point in time, I would ask that Mr. Scott Kiefer and Mr. Eric Hogue come to the testifying podium and present yourselves and begin your presentation. And thank you for joining us and sharing information. Appreciate it.
Mr. Chair and Senators, thank you very much for the opportunity to be here today. It's a pleasure to join you and talk about healthcare costs. I'm Scott Kiefer, Vice President of Public Affairs for Blue Cross Blue Shield of Minnesota, and I'm delighted to be joined by my colleague, who I'll let introduce himself.
Hello, I'm Eric Hogue, Vice President of Provider Relations, so I oversee the provider relations and network functions at Blue Cross Minnesota.
Again, thank you, Mr. Chair. It's a pleasure to be talking about something other than the Affordable Care Act and what we find ourselves digging out from under, and to have this broader discussion about healthcare cost. And I'd like to start by thanking you and your colleagues for taking decisive action to help, first of all, for all those who are suffering with the high cost increases and the challenges presented by the law. Obviously, it hasn't gone as we had hoped. That's been difficult for Blue Cross. I recognize it's been particularly difficult, especially for those Minnesotans that are outside of the subsidy range. So thank you for the prompt work last year with the 25% subsidy, and as well for the reinsurance program, which we're seeing the fruits of, and I know the Department of Commerce is moving forward and implementing. Today's discussion is really important because inasmuch as we've been talking about the Affordable Care Act, and for those that are in the insurance pool, some say, well, it's only 5%. There's an old adage that for the guy that's unemployed, the unemployment rate is 1,000%. So again, for those that are in the market, it's really important. But healthcare cost and the desire to have lower cost, to reduce that cost trend, as you say, Mr. Chair, is something that unites all of us. We'd all like to have more transparency, cost, choice, and competition, so we're going to talk about that today. And for Blue Cross, as the leading health plan in Minnesota, we like to say that 1 in every 3 Minnesotans carries a Blue Card. This is critically important for a segment of our business that we sometimes forget about, but still is the predominant source of coverage for Minnesotans and in the United States. And that's all of those in the employer-sponsored market. So on behalf of our employers, whether it's the Medtronics or 3Ms of the world or the city of Eagan, the smaller groups, we appreciate that. 60% of Minnesotans under the age of 65, and 60% of those nationally. On a national basis, about 160 million people receive their coverage through group markets, so that's really important. For the committee's benefit, a way to think about this in the scale of the pressures that we have on the employer group markets, our spend as a nation on health care is about $3 trillion. Government actuaries tell us that about $1 trillion, or about 1/3 of that $3 trillion, is direct spend by employers. So put that in context. You're probably wondering why I'm saying this, and the reason is that that number of those covered by employer group plans has ticked down over the last decade. Roughly about 7-8% fewer individuals receive their coverage through the employer markets. And of course, as taxpayers, we'd prefer to see more people in private coverage, so it reduces the burden and the crowd out of other governmental resources, whether that be in education, law enforcement, or transportation, those priorities. So to put it in that context.
Sir, if I could interrupt, I'm going to ask you to repeat the last 3 minutes, because I think that's particularly important for all of us to understand. Would you go back to that we spend approximately $3 trillion, and then talk about how much is paid by the employer? I think you said $1 trillion, and that employer, could you also make a comment? Are there additional dollars above that $1 trillion that are paid by employee portion of that premium, or is that employer including the employee portion of the premium as well? So if you could just take us back, because I think this is really important for us to understand. Thank you.
Yes, sir. Mr. Chair, if I may, government actuaries from the Centers for Medicare and Medicaid Services, where these are career people, they're not political appointees, longitudinally over 40 years have looked at healthcare cost. The share of spend that is a portion of GDP, which is roughly about 17.5%, is often talked about. What's not often talked about at the national level and in our discussion in the news is the portion that breaks down. So it's correct that about 1/3 of that, about $1 trillion of $3 trillion, is employer dollars. And within that, a big portion is also what individuals pay in out-of-pocket. Of course, we've seen those out-of-pocket costs rise. So I know you've heard from the health department, earlier panels we were talking about low-value care and how much is spent. I think the health department, the health economics division talked to you about a recent report that they had. So it's important, again, that we think about that in the context of making sure that the coverage is affordable for our employer community. Eric and myself and colleagues hear about that every day, the challenges that employers face and the increasing burden of healthcare costs. And many of those are declining to participate, staying out of the market. So we want to make sure that those costs are stabilized. I only say that because, again, much, if not most, of the discussion has been around the Affordable Care Act, those that are in the individual market. That's an important issue as well. But for Minnesotans and the nation, roughly 60% of us that are under age 65 really still receive their employer coverage, health insurance through employer coverage. So that's the importance of what the point that I was making. I do want to make one other comment, and that is there's often interest in why costs are much higher in the individual market. And I would suggest to you that the individual market is largely an auxiliary insurance market. I don't mean that at the disparagement of any colleagues at Blue Cross or any individuals that are in the individual insurance, but if you're there, it's because you don't have an employer offer another source of coverage. One of the important variables in the cost conundrum is that in an employer group plan, we receive a great tax benefit from the federal government in that our employer benefits are not taxed to us as wage income is. For those in the individual insurance market, that's not the case. The result is that individuals often say, what can you do to lower my premiums? And the consequence is, well, we say we can have a higher deductible or you can have higher out-of-pocket costs. So I think that's important foundationally in understanding the insurance picture. One last point before I turn it over to Eric to talk about some of the specific issues and some of the specific programs and initiatives that we have to reduce costs is to suggest to you that I'm particularly pleased today because the headline is often around premiums. We often don't get to talk as we'd like about those upstream costs in that premiums follow health costs. So I would suggest for the committee's benefit, the dollar that we often share, which sort of breaks down the fact that roughly 90 cents on the dollar is spent through the medical spend. Of course, as you know, Mr. Chair, the lion's share of that is in the inpatient and outpatient hospital setting, roughly in the middle 40%. But just an important reminder to the committee, and with that, I'll be happy to turn it over to Eric and do the heavy lifting.
Perhaps you could do a little bit of lifting prior to turning it over. Could you comment on the 10% that goes to administration? I think there's some confusion about that. What does that include exactly, the 10% that's carved out? And does that change in regards to the managed care contracts you have with medical assistance patient populations?
It does. Thank you, Mr. Chair, if I may. As you see there, the 10% includes generally what we categorize in our filings with the state through the National Association of Insurance Commissioners as administration, taxes, and fees. I've included with the documents for the committee's benefit our Blue Basics materials, which show, for example, that as a not-for-profit health plan, Blue Cross Blue Shield actually pays taxes. You can see the amount there. It's north of $100 million with the latest information. So we have various fees, taxes, some of those at the state level, some at the federal level. There's a portion of that. The other portion of it relates to our claim spend, what we spend in the claim system, what we do from a care management standpoint. People are surprised to know that at Blue Cross, for example, of our 3,500 employees, roughly 10% or about 300 of those are registered nurses, nurse case managers that are providing care. So it's employees, it's taxes, fees, the administration. And then specifically to your question around medical assistance, those administrative charges or fees back to the state of Minnesota are set. I believe the current rate is roughly 6.9%. If I'm remembering correctly, Milliman, actuarial firm that the state of Minnesota uses, did a report, I think in 2015, that actually found that Minnesota had the second, we're not first, we'd like to be first, but the second lowest administrative cost in state-funded government programs in the country.
Thank you.
Yep.
Mr. Chair, Senators, thank you for having me here. I'm very passionate about healthcare value, and that's what we want to talk today is how do we deliver that, and what are we doing at Blue Cross to frankly bring that value to our customers, our members, and to employers, as Scott mentioned. And my whole career has been in healthcare. I actually came from the provider side where I worked the rest of my career to Blue Cross in 2011. It was really to figure out how do we work together with providers to really improve the value equation. And when you think about the value equation, what is healthcare value? There's really, to me, three elements of that equation. One is improving the health or outcomes of members. The second is containing costs or making healthcare more affordable. And the third is elevating the experience of the member, which is often referred to as a triple aim. And that the experience of the member, I think we talked, some of the people spoke earlier about, is that getting an engaged member through either when they purchase healthcare or else how they use healthcare, I think is an important element of this equation as well. So if you look at kind of what are the various levers that Blue Cross has at its disposal to manage healthcare value, there's really three major elements when we look at this. There's price or unit costs, essentially what is the price we pay providers. The second is what's the severity that impacts that. So the more severe the patient, the more complex, that can increase costs. And the third is the underlying utilization. So how many services are provided. And Mr. Chair, I think we actually have data, and we're using a vendor called Roadmap that actually looks at utilization and practice patterns that about 20, per Dartmouth Atlas and some of the kind of national publications, that 20 to 30% of services are unnecessary due to variation, unwarranted variation that is unexplainable. So we're really focused on that as part of this process. And that gets into the various levers. So on one side, we have the care management function at Blue Cross that really is looking at medical levers. It's looking at case management. So how can our nurses more proactively care manage our patients, help with aids and aiding them and members in transition of care. Also having appropriate medical policies and utilization management to once again ensure that appropriate care. The mantra we use is right care, right place, right time. And those elements are really to ensure that. And then on the pharmacy side, you have formularies that are used around the pricing once again, and also utilization management to ensure that people are getting the right drugs that will make sure that they get better and it's necessary. On the network and payment side, which that's the area I live in, there's multiple levers there, and provider contracting and negotiations and just setting the price is one. The second element is network configuration, which is determining how do we get members to the right provider that will take the best care for them and in the most cost effective method. We also have different payment methods. How we pay providers is important. The traditional fee-for-service model that is still pervasive in our market, over 98%, about 98% of our payments are still on fee-for-service, which is still too high, is you're rewarding every service on a kind of a per widget basis. And we believe the further we move away from that and align incentives, the better. And then on the pharmacy side, on the network, we also have just network configurations and, once again, pricing. So the one thing in Minnesota, which is maybe a little unique compared to other markets, is we have a lot of consolidation. So over the last 20 years, the market has continued to consolidate. Independent physicians have joined large systems, and we have really set up here, we have on the screen above, we have 7 major systems that actually make up over 50% of our medical spend across Blue Cross. So that's a lot of consolidation. It depends on the geography, but at the end of the day, it can be a challenge especially on the pricing equation. Whenever you get 2 large entities talking price, it can lead to difficult negotiations and discussions. But it also can lead to a benefit in that you can actually scale up programs more quickly. When we launched our value-based programs back in 2011, it was right when I was getting to Blue Cross, we were going to pilot a couple. And then other providers got word of it, and all of a sudden, within a year, we have 10 of those programs. So it allowed us to scale up, and when we work with these providers, we're touching over 50% of the spend in our system. So it can be a benefit or a little bit of a challenge. The next slide is really getting to some of that variation that we talked about in pricing. So this isn't even practice variation, which is another element in utilization. But there's a lot of cost variation across the state of Minnesota depending on geography, which provider is billing, et cetera. And what you see on the screen is some of our normal, kind of more typical services that may be done in the hospital, and then what is the lower and upper range of the price for that. So what you see here is there's a lot of variation. And we've gone through some processes over the last couple of years to try to shrink down this variation. But in addition to that, it also creates an opportunity to help steer members, if we can educate them appropriately, to that right provider that is cost effective and high quality. And what we've found generally when you look at some of these data points is that the providers that are managing cost effectively also happen to have probably at average or above average quality scores. So just because someone's high cost does not mean by any means that they're necessarily any higher quality. But we also are looking at this at a very specialized level, and some people are good at very specialized services, others are not, and this is really part of the overall equation. And so this is part of what comes into play when we talk about our network designs that we've put out in the market for Blue Cross to help manage some of this variation. We also are trying to help members get guided to the right provider.
Mr. Chair.
Prior to moving on, I think we're going to entertain a question from Senator Pratt.
All right, thank you.
Thank you, Mr. Chair. And this is an extremely interesting chart to me, and I guess, do you tend to find the higher cost providers in greater Minnesota where maybe they have fewer people requesting a procedure, or do you see it more in the metro where office space and everything else is more expensive, or geography doesn't matter?
Please proceed.
Thank you, Mr. Chair. Thank you, Senator Pratt. I would say that in general, we do see higher costs in the outstate, and it does come to kind of the underlying economics that there's fixed kind of assets and there's a fixed expense structure, and so there's somewhat a naturally higher price in those cases, and also geographic. If you're the only provider in a geography, also that can kind of lead to kind of the supply side setting the pricing as well.
Senator Pratt, follow up.
So it sounds like from your last comment is we have high price providers because they can charge a high price, and unless someone like you is looking at it, they just get paid without a lot of oversight or challenge.
I would say that there's a healthy tension between the health plan and the provider that can frankly help control costs, and that is one of our roles. In that we have a certain view, and our view is to really deliver the most cost-effective premium to our members. So you go upstream, and I worked on the healthcare provider side, and they have their operating expense challenges. I think a big piece of this is also what we continue to hear from providers is the cost shifting, and the cost shifting that more and more membership, Scott talked a little bit earlier, was more and more of their patients are being coming through government mechanisms that generally pay lower, as I think you mentioned earlier. So that's a dynamic that sometimes we're at odds a little bit, and we have to work through. But I think it is good for, maybe I'm just touting my value, but I think I think there's some value in what we do, obviously, to help control those costs.
We'll make sure your boss gets a copy of the tape.
All right, sounds good.
Thank you, and I'm going to do a follow-up question if I could. As a physician of 31 years, I certainly shouldn't be shocked by this, I suppose, but I still am. When I look at just a standard office level visit ranging anywhere from $15 to $700, you said there's a healthy tension. Perhaps we need to try to create an unhealthy tension because this is astonishing, and colonoscopies from 1,000 to 6,000 and things like that. And I imagine you have slides like this that would indicate that the variation in cost in pharmaceuticals is also got that kind of a range. And that's why I've been an advocate to make certain that we retain the prior authorization tool for insurance companies so that they can indeed try to hold down the costs. That isn't to say that the prior authorization process couldn't be improved at times, but nevertheless, it's an important tool. I would like to just ask a question about trying to standardize fees instead of allowing this kind of disparity, particularly in regards to primary care. You made a plug, if you will, that you thought that 98% fee for service is far too much and we need to move away from there. But it's hard to bundle, and it's hard to be holding physicians accountable to outcomes when what's happening in so many primary care offices is a patient's calling in with a cough and a fever, and they come in and their cough and fever is taken care of. It's hard to pay that provider in any other way other than a fee for service, if you will. Nevertheless, in a situation like that, if everybody were receiving in a geographic area the same, that might make more sense than the present situation where you have one clinic and a provider receiving $95 and another receiving $135 and another receiving $175, and having some clinics receive $19 for a strep screen while another clinic might receive $79 for that same test. Would you comment on that, please?
Mr. Chair, thank you. Yes, so I think you are correct that we need to try to work really both angles. It's It's how do you shrink these gaps up here, and whatever mechanism you can do that. In addition to what you said also resonated a little bit is that even if you get more and more to value payments, the example of if someone calls in and has a cold, I'm getting over a cold, I've received no care for that except for water, and when they come to the office, what I think when we get to these new models with providers, what it does is really align our incentives to try to do what you can. Now, you can't always prevent that patient that wants to come in and be seen or will maybe hound you for a prescription that maybe is unnecessary. But I think it does align where potentially there's different types of outreach. You can do telemedicine, et cetera, to alleviate that. Because I think actually doing that will even create more value if we can get there. But there's definitely some challenges to that, obviously. So I think it's kind of a both. And when you look at this, we see similar, if we looked at kind of utilization variation, we have a partner roadmap that we're working with that looks at variation on practice patterns using Dartmouth Atlas methodologies. And they kind of do a similar mechanism to say, are physicians practicing kind of within standards of care, or are they doing things more aggressively? Because then that's a multiplier effect. If you have a provider that's higher price and also doing more, it can really exacerbate the issue.
Last December, CEO of Blue Cross, Michael Guyette, had written an op-ed piece in the Minneapolis Tribune, and the last sentence, I think, in his op-ed was, we've talked about how to pay for things, and we've done this and we've done that, but at the end of the day, the one thing we haven't touched base on is cost. And so I appreciate your attention to this, and again, I appreciate your willingness to present to us today and help us try to understand how we might bend that cost curve. Senator Kiffmeyer.
Thank you, Mr. Chair.
Thank you, Mr. Chair. Well, very interesting information from all of our presenters today. One of the things that I have seen that I think has probably bent the cost curve down is just in a little way amongst the family members of moms and so on and so forth, and their conversations about antibiotics for colds. Remember the old adage used to be, how long will your cold last? Well, 2 weeks with an antibiotic, 14 days without. Basically, the idea is if it's a viral thing, it's going to run its course, and symptomatic treatment, whether it's over-the-counter things, are all very helpful. Water and chicken soup still works quite well. But the fact that it has gone down, that education and that knowledge and information has gotten into a lot of the mom and dad pool, regular folks who understand and who have learned that that kind of patient education really works. So I have two questions, but this one is in regards to that kind of evidence-based education with your providers through your network of Blue Cross Blue Shield that helps a consumer to make choices, that gives them all the appropriate care, but yet also lets them know there are ways to take care of this, and it doesn't always have to be a prescription or a procedure.
Please proceed.
Mr. Chair, Senator, a great question. And Blue Cross worked 2 years ago to establish a health literacy coalition of approximately 42 organizations for just that purpose. I think that obviously in the healthcare system there's a lot of jargon. I think moms and dads are challenged with trying to make sure that their kids have a good pair of boots for the upcoming winter. And have a hard time deciphering the code from a deductible or a copayment or what have you. So I think health literacy is a big part of that. I think to weave together a little bit of your question with the chairs, the last question, we all need to do better on the transparency front. So a big portion of our spend, for example, relates to the 50 top conditions. And I think Eric could talk about what we're looking at with respect to bundles. We know that there are a lot of people who are getting joint replacements, specifically hips and knees, and you see the variation in those up there. So we need to make sure that there's actionable information for consumers. I think foundationally, we need some support from a data standpoint. So we have Minnesota Community Measurement doing some work, the state of Minnesota doing some work. There's a big database now of national insurers, including United and Cigna and others out of Washington, D.C. that's put some data. So I think one of the things that we need to figure out is what it is that the state of Minnesota can do to support transparency, to support some rationality to the pricing system, whether it's some reference-based price that would be a target, and then you would look at the outcomes within that, or to look at something like what Maryland is doing with all-payer rate setting. Maryland is the only state that has a quasi-governmental board that sets rates. I'm not so sure I would recommend going there personally, but there's a range of things that we can do to make sure the consumers have that actionable information, Senator, so they can go to the Y clinic as opposed to the X clinic. Eric?
Yeah, no, thank you. Yeah, and so I think this is really timely because we just were in a conversation with a provider in our network that happens to do one of these services up here and about bundles and how do we create there's elements of how you can help the member get there. One is kind of what we might call as hard steerage, which is benefits, network design, or some type of soft steerage where they go out to our website with transparency can better understand either education of what should I do if I have a cold, or if I have this condition, which provider should I go to? And so we're working through that. But as Scott said, I don't think the healthcare industry in general has been great at overall transparency and helping people shop or make decisions. And that's something we all collectively, I think, need to get better at.
Thank you. Senator Kiffmer, follow-up?
Yeah, well, Mr. Chair, just a little bit different approach. I noticed that about on your dollar thing, which is always a nice way to look at it. And so part of it, 15%, is the prescription drugs area. And so you have a very nice on procedures kind of a range. And one of our kind of conversations was also the disparity or the ranges in prescription pricing of drugs. Do you have any sort of range, the same sort of variation thing that has to do with maybe pharmaceuticals?
Please proceed.
Mr. Chair and Senator, thank you. A great question. And both Eric and myself sit on our internal coverage committee, which is our governing body to approve medical changes brought forward by our physicians and clinicians. And I would tell you that one of the things that we discussed in the last meeting about a week ago is a new drug for ALS, commonly known as Lou Gehrig's disease. I'm sorry, the name of the drug is escaping me. It's $145,000 per year. I listened to 5 of our doctors, unanimous in believing that that drug provides no additional benefit over similar drugs that have been out for 20 years. And it would require in the neighborhood of 160 separate infusions for an ALS patient on the annual basis. So we're talking about them being infused roughly every other day at 14-day intervals at $145,000 a year. So I appreciate the plug, Mr. Chair, for prior authorization, because this is a drug that we're in active conversations with the neurological community around what we're going to do about this. Because our docs have no earthly clue why it should have been approved by the FDA, but yet it was. So I only give that an example again, and I'm only sharing what physicians have told me, and it's my job to make sure that the right questions are asked. But it is a real vexing challenge when we look at the high cost of drugs. I would give you one more example and tell you that in our individual business, from 2014 to 2016, when we had very acute challenges and very, very rapid premium increases, the number one category of drug growth was for Humira and Enbrel. Now, the chair knows as a physician what those drugs do, but if anybody who has rheumatoid arthritis or a family member knows that they're life-altering. They work very effectively for rheumatoid arthritis, and they can help people retain normal function. They're also about $3,000 a month. So I would tell you that in something that costs roughly $35,000 a year, there's no way we can write enough premium unless we have a very, very large pool, which is part of the conversation. My point is that those drugs are very effective for rheumatoid arthritis. We're now seeing Humira advertised on WCCO at 10 o'clock, for those of you who watch the news, for other autoimmune indications. Now, I'm not a clinician, again, but we have experts back in Egan, physicians and clinicians that tell us, and they question whether those drugs are as effective for other autoimmune conditions. So again, this is part of the role that we play in the system. It's not always one that's easy when we're telling consumers they have to try something else first, but it's an important part of the gatekeeper role.
Thank you, Senator Kiffmeyer. And if I could put another plug in for you on this one. it frustrates me immensely that my colleagues are so willing to take a drug that gets approved for one indication, like you say, powerful medical problems such as rheumatoid arthritis, but within a couple of years after, it's now being used for mild psoriasis. Psoriasis was being controlled by drugs that cost $25 a month, and patients are being advised that perhaps they should go on Humira. And it just astonishes me. So I think physicians certainly could play a better role in this problem of trying to bend the cost curve downwards. So I'll let you proceed. Thank you.
Mr. Chair, thank you. And just to actually add, even before I move on the drug front, another element of this is also the site of where you receive an infusion. So depending on where you get the infusion, if you get in the hospital or in a clinic setting or even at home, can alter the cost greatly. So we're actually looking at strategies at Blue Cross as how do we encourage some of those lower cost settings to accompany the drug that is kind of a maintenance drug or of the like. So, well, we've talked a lot about the issues, so I wanted to talk about some of the solutions we're trying to put in place to meet some of these challenges. And now, none of these are silver bullets, but I kind of want to highlight what Blue Cross is really trying to do to help manage various elements of the cost concerns we have in the industry. So what we're doing is, I think everyone here would admit that diabetes is obviously a large issue. It's a societal issue. With the increasing challenges within our community, we've seen obesity rates go up. And it's a progressive disease that once it starts, it can get worse and worse and have complicating factors around vascular disease, et cetera. And so at Blue Cross, what we've done is we're doing a diabetes pilot with 3 large employers in town. And one of our standard benefits is that people have access to a diabetic health coach if they need one. An education, basically they educate the member on diabetes, but only 6% use that benefit today. So we're trying to figure out how do we increase that benefit, and why were people not really be more engaged in the diabetic front. And a lot of this is trying to engage them early if they are first diagnosed so that we don't have that progression of the disease. I think in Minnesota, I think we do pretty well as you can managing diabetes once it's progressed. But I think there's a lot of opportunity either in the pre-diabetes phase or once diabetes is actually diagnosed. And so what we've done is one big lever that we're pulling is putting in value-based benefits and also getting some digital enablement where our health coaches or nurses can actually work with members that have diabetes more proactively. But on the benefit front, what we're finding is, and this is where the discussion around high deductibles, the one thing is if it's not a preventive visit, I think it does definitely impact and make people make decisions, but sometimes there can be short-term decisions that are made without figuring out the long-term impacts. So some with diabetes, if you're not taking your medications because you don't want to pay the copay or pay the dollar amount out of pocket, you can actually speed up the progression of the disease. And so what we're doing is covering some or even in some cases all of the supplies for diabetics and necessary medication to make sure that they're in compliance with their care pathway. And so overall, we expect and have already seen a little bit of this at, in general, our health coach engagements percentages. So when we reach out, how many people actually engage and stay working with a health coach is about 3 to 5%. I think that's pretty much in line with industry standards. That for this model, we are expecting it to potentially go up to 30%. And so we're just launching this pilot, and we're obtaining data. But once we get the data in, we're going to determine how is it performing, and then also do we need to tweak it or how can we expand it. But overall, it's really a way to how do we look at diabetes a little bit more comprehensively and not in any type of short-sighted manner, because it can be a really big driver of healthcare as someone progresses in age and through the disease. Another example of kind of a more comprehensive solution that we've looked at is our living kidney donor program with Mayo Health System, or Mayo Clinic, actually. So the model here is to figure out how do you change the model of care for people that have end-stage renal disease, so people that are experiencing kidney failure. And in general, what happens is someone reaches a certain point. Now they are put on dialysis, which does not cure it. It just buys them time until they can get a transplant. and that can occur between 2 to 3 years. The average cost, it can be upwards to over $200,000 per year for dialysis. It requires the patient to go 3 times a week for about half of a day. So you can think about from kind of an employer perspective and absenteeism, just the patient themselves of having to do that on a weekly basis is very disruptive. In addition, there's data showing that if someone can have a living kidney donor transplant versus a the cadaver, yes, cadaver transplant, there's better outcomes. So we've put this model in place with Mayo. We are piloting with some large employers. But the idea is to actually look through our data to identify people that are approaching that stage of when they might need dialysis. And then Mayo Clinic actually has the largest unrelated basically bank of living kidney donors because of all the matching that it can do across the country and secure a living kidney donor transplant prior to them going on dialysis. That's actually shown to have superior outcomes, and Mayo Clinic is actually a market leader in their outcomes just overall on kidney transplant. We've also set up a bundled price, so this whole process is one set price. There's coordinated member experience through health coaching engagement. But overall, we think it's really the ultimate kind of triple aim and hitting all those levers that we talked about in healthcare value. It's more cost effective. Just in basically the cost of this is probably less than half a year of dialysis. So it's more cost effective, better quality outcomes. And from a member and patient experience, it's vastly superior as well. So this is just one more example of where we're trying to innovate with our providers. And then lastly, I just want to kind of close on a timeline of all the different ways we've been trying to move the needle. And it's really a timeline. As I mentioned, back in 2011, we launched our aligned incentive contracts, which is our precursor, or basically our first value-based model. It was with those large systems you saw on the screen earlier. And it was really around setting up quality metrics that providers were now accountable for and managing costs. And what we've seen definitely is, from a quality perspective, when providers focus and you put, frankly, money and incentives towards those quality measures, it allows the provider to have time and attention and allocate their resources to move the needle. And so we've seen a positive benefit, and especially in these programs when a member is in them for really a 2 or longer year period, we find that there's really a value, a return, if you will, on kind of the incentives we're paying out to providers that accrues to end up lowering the cost overall. And so that's in 2011. In 2014, we launched our accountable care organization products and networks. These are now, we have our regional networks that we're using in the individual market. And the goal of this was to have a focused network that drove members to certain providers that were similar, either through ownership or through having kind of shared interest. Our Blueprint and Allina product has independent providers and Allina in it that work together as a clinically integrated network. And so it's really looking at how do we coordinate the care more holistically within the network, not just working on payment, but also looking at the care model in total. And then what I'll probably close on is that in 2015, we started down the road of bundle payments. So this is getting at how do we create a model that makes it a little bit easier for members. There's one price. What we've done is how we have these in place with a few orthopedic groups that are focused around total joint replacements for knee and hip, and then spine and shoulder we have. And essentially what happens is the bundle starts on the day of surgery. There's a 90-day period afterwards, PT, all that's included. So people that have to get physical therapy, and if you're paying out of pocket each time, sometimes you kind of taper off and decide not to come anymore. That's a barrier that's removed. And there's actually some elements in there. There's a little bit of element of risk that if there's admissions back to the hospital, that there could be some financial incentive or penalty there. And overall, we've launched these. It's mostly in the metro. We're working with a couple outstate providers as well on bundles. The immediate savings is who we've been working with are the independent providers that are outside the hospital. So you get kind of immediate savings because you're moving to a lower cost setting. but we're also looking at how do we expand this to within the hospitals to get kind of a more, a better value proposition across kind of whatever site of care continuum are. We also are looking at expanding this in different markets. We actually have launched an OB bundle down in with Olmsted County Medical Center. And so we're looking at obstetrics. We also are potentially looking at gastroenterology. And overall, we just think this is a mechanism that helps the member, frankly, price and shop. And also what it does is create a competitive marketplace where if there's a price out in the market and someone knows that's what it costs, and another provider comes to us and say, well, I want to do a bundle, but it's $5,000 more, we might say, well, we're not going to do a bundle. We don't really want to feature because they're a mile and a half down the street. We think that people should be going there. There's similar outcomes. So that's an element of kind of our network design that we're trying to build on top of kind of everything else we've talked about. Yeah.
First off, you mentioned gastroenterologists, and Anthem, I think, is your parent organization.
The individual Blue Cross Blue Shield companies are independent, so Minnesota is a completely independent company. Anthem is a conglomerate of a number of Blue Cross Blue Shields in California and Georgia and around the country. So, yep. But we do partner within the Blue Cross system. So, for example, a Medtronic employee, whether they're in California or Minnesota or Texas, is a Blue Cross Blue Shield of Minnesota card member. So so nationally there's a system by which the Blue Cross Blue Shield members are kind of shared, if you will.
Appreciate that. Thank you very much. Anthem came out about 2 months ago and indicated that they were going to no longer pay for MRIs that were done at hospital facilities when they could be done at other facilities on an outpatient basis. I think that was an excellent move. There's MRIs that are available for $600 in some places, and you'll pay easily $3,000, $4,000 in a variety of hospital-based facilities. So the same thing with colonoscopy, and you'd mentioned the gastroenterologist. And I know that at the hospital I work at Ridgeview in Waconia, they bundle $21,000 is what they do for a joint replacement, and that's everything. And the bundling takes care of not getting charged $10 for a Kleenex or $2 for a toothbrush and things like that. So I think it makes a lot of sense. How do you think we, as a legislative body, can piggyback on top of those kinds of efforts and bend that cost curve downwards? If you were king for a day and you could make 3 proclamations and say this is the way we're going to do things, what kinds of things could we do that goes along that line of bundling?
So thank you, Mr. Chair. I believe there's definitely a lot of opportunity. I think one is I've laid out some of those levers that are available to us to help manage the cost. So I think supporting us and the ability to continue to use those levers, judiciously, obviously, and smartly. But I think those are important. As you mentioned, the prior authorization, I think, is an important element that can sometimes seem overburdened and red tape that's unnecessary. But in actuality, what it's doing is helping ensure that there's appropriate care being provided. So I think that's one element. I think the second one is when looking at various legislation and regulation to understand the connectedness across all of the segments. When we talk with providers, have negotiations or just overall discussions around the cost shift, et cetera, there's an element that can be kind of a whack-a-mole scenario where if you do one thing on one segment, it can just pop up in another segment. Because at the end of the day, the providers are trying to operate their business for their total patient base, regardless of their payer mix, if you will. And so I think just remembering that and keeping that in mind, so if you're working on individual legislation, that could have ramifications elsewhere depending on what it is. And then I think the third one is just support. I think earlier was talked a little bit about privacy laws. I think that's one area that in Minnesota, I think we have a little bit more stringent privacy laws and with data sharing. And what we're really trying to do with providers is get them claims data so they understand, because when you go into a provider's office, they don't know about care that wasn't inside their walls. So we want to be able to get them information that can help manage that patient more holistically, potentially. And then on the flip side, we don't have information sometimes on the clinical, so some of the lab tests, et cetera. And so we're interested in being able to get some of that in an efficient way. So I think starting to think about how can that be done while protecting the interests, obviously, of the patients and members to ensure that we're doing that appropriately. I think finding that balance would be an important element as well.
Thank you. Appreciate it. Other questions, comments? Senator Pratt.
Thank you. You raised an interesting question. I haven't asked yet. So you get the benefit of being the first to respond to it. And you talked about regulation, and every regulation carries a cost. Are there regulations that are increasing the cost of health care that are adding very little benefit in your opinion?
Mr. Chair and Senator Pratt, I'm looking at my wingman here too. Yeah.
I think, Mr. Chair, Senator Pratt, great question. I think that we're always wary of health plan taxes and fees, and I think the fact of the matter is some of the most challenging pieces of it are those that only impact the fully insured part of the marketplace. So there's some irony for me that we've been talking an awful lot about the individual market and the small group market, which are relatively small, but because of ERISA, state law only allows those parts of the market to be hit by taxes and fees. So sometimes those state taxes and fees, if they're not broadly based, they can have a real disproportionate impact on the coverage. So I know there's a lot of controversy about the provider tax. I would say that one benefit of the provider tax, and you've heard this from the insurance side before, is that it applies across the broad base. So I think it's really thinking about how the regulation can have the least negative impact or unintended consequences. So again, some of those taxes and fees that I showed you that we pay apply only to a very negative slice of so that's sort of the first thing that comes to my mind. I also think that when we look at some of the benefit mandates, it's true that historically, and the chair can speak to this from a clinical standpoint, I think historically we've seen a lot of benefit mandates that over time prove to have low value. Perhaps the worst case of those is the autologous bone marrow transplant that I think a lot of women went through. And if I remember correctly, there were some 15 or 18, nearly 20 states that had mandated that at one point. So I think, again, the part of the question for me sort of circles back to this idea of healthy tension in the system. And the previous panelists talked a little bit about medical necessity. Medical necessity is a conversation that evolves over time to include clinicians in the health plan and in the clinical community. And that's something that, really should largely remain there to the extent that that is possible. So I would say a minimalist approach to regulation rather than saying, smart regulation, dumb regulation type thing.
Senator Pratt. Oh, I'm sorry. Please.
Can I add, Mr. Chair and Senator Pratt, that one other element I think that to think about is we look at some of our network adequacy requirements in the state. Obviously, there's that balance of ensuring appropriate access, but also when you think about something like how subspecialized and granular do you get? So an example is if there's a requirement for a subspecialized coverage in a very rural setting, in some ways it's just not necessarily practical or even cost effective to have a neurosurgeon planted out in a community where they might see one legitimate neurosurgery case in a given period of time. So I think that's one where I think there's exception processes in the state process right now, which I think we're able to meet that through that process. But I think that's one where of having that kind of tension, because when I worked on the provider side, if you have to have some of these specialties driving out or actually having a location out there can not be the most cost effective, if you will, or use of that subspecialist time.
Thank you.
Senator Pratt, follow-up?
No, I think that's good. You had mentioned something about sharing information, got me on the regulatory piece, so thank you very much.
Yeah, we had spoken in previous meetings about sharing information and trying to not have duplication. And it strikes me that we do have a tremendous opportunity for patients to carry their own information in their phone. And then it's always there. And I know it's difficult for one Epic installation site to necessarily communicate with another Epic installation site. And I think at some point in time, hopefully we can make more progress in allowing patients to carry with them their vaccine record and their medication record and their allergy record and things like that, because there's usually about 6 to 12 pages of information that's helpful, and the rest of the 1,000 pages of electronic health records are relatively garbage. So thank you. Any other questions? Senator Kiffmeyer.
Thank you very much, Mr. Chairman. And so one of the things that I have found in just over the last years, there are many times being a nurse and stuff, I'll be asked to work with the family or support them or go with them. And one of the ones that happened was having to do with evidence-based medicine. And the patient had a procedure, had internal bleeding. And it's a little bit scary to see their hemoglobin go from 16 to 15 to 14, 13, 12, 11, 10. And I'm thinking how low we're going to go before we do an intervention. And we go down and we're at 7. And I'm thinking, okay. So we're looking at these things. And the most important thing was the physician, hospitalist, in this case, that came in and took the time to explain why the evidence showed and why it mattered to the patient. Not to them on cost, not to them on their time or use of resources or anything else like that. Because many times in these cases, you deal with a large patient population, but to a patient, they are the only population that matters at that time. But because they took the time at 2 in the morning to explain that from a patient-centered point of view, things did stabilize. And the risks of an additional surgery and the possible complications that come from that were avoided. And a couple days later, went home and things resolved. And it was just to me to see the value, though, of taking the time to talk about that from a patient-centered point of view. And too often, it is not quite done that way. And then you end up in the situation where fear takes over and somebody's got to do something to fix it instead of allowing the body to actually do its own resolution, which it often may do. But they took the time to explain it. So I think for me, I have found that too many times patients are not treated as pretty smart people who generally, with some good information and giving them time, can kind of figure these things out quite well. And incidentally, will also help save the system. And so I want to encourage you in regards to some of the things that you've talked about here to continue to focus on that and treat patients in that sort of way, because I think there is a return in many ways for that. But unless we engage the actual consumers making those decisions, and also even in the providers in doing that, I don't think we're going to bend the cost curve down, because otherwise the rush will be always to do something to fix it, and it may not be the best decision.
Thank you, Senator Kiffmeyer. I want to thank you again for presenting. It was a robust discussion, and it enlightened all of us. And I'd encourage you to reach out if you have other ideas, to reach out to any member of the committee. This is truly a situation we're all trying to pull the rope in the same direction. So thank you again. We're 5 minutes ahead of schedule, and we are going to try to adjourn 3:45. Any concluding comments by any members of the committee? Seeing none, just a little housekeeping detail. Our next meeting is October 26th, Thursday, 1 p.m. Following meeting after that would be November 9th, 1 p.m. Right now, we're tentatively thinking about having a public testimony hearing on Thursday afternoon, 1 p.m. On December 7th, the first Thursday, we were thinking of having public testimony, and that would be our last meeting of this calendar year. Any questions on that? All right, thanks so much. The meeting is adjourned.